Endotracheal intubation is the placement of a flexible plastic tube into the trachea to provide respiratory support. It is frequently performed in the critically ill to facilitate gas exchange in the lungs. Indications for intubation and mechanical ventilation are mental status changes, hypoxia, hypercarbia, weakness, or the inability to maintain a clear airway. The most widely used route is oral tracheal, in which the endotracheal tube is passed through the mouth and vocal cords into the trachea. The nasotracheal route can also be used. This is what the endotracheal tube, abbreviated ET tube, looks like. The balloon located at the distal end of the ET tube ensures that a seal is made against the tracheal wall, preventing gases from leaking. Because it is an invasive and uncomfortable medical procedure, intubation is usually performed after administration of general anesthesia and a neuromuscular blocking drug. It can, however, be performed in the awake patient with local or topical anesthesia, or in an emergency situation without any anesthesia at all. The vast majority of tracheal intubations involve the use of a viewing instrument of one type or another. Since its introduction in 1895, the laryngoscope has been the most popular device used for this purpose. Nowadays, the laryngoscope consists of a handle containing batteries to energize a light source at the end of the blade to allow visualization of the larynx. Let's now look at a live intubation and identify the anatomy. As you can see, the tracheal inlet is right here. To the right and left of the tracheal inlet is the vocal cords. At the top of the screen lies the epiglottis, and at the bottom of the screen is the aryepiglottic fold, encompassing the laryngeal inlet. Take note of the epiglottis' distinct horseshoe appearance. Once the vocal cords are identified, the ET tube is passed in between them into the trachea. It is important to note that the esophagus lies posterior to the larynx, and one must make sure the ET tube does not end up in there. Here you will see the endotracheal tube being delivered and placed through the laryngeal inlet into the trachea, completing the intubation. After the trachea has been intubated, the balloon is inflated to help secure it in place to prevent leakage of respiratory gases and protect the tracheobronchial tree from receiving undesirable material such as stomach acids. There is a finesse required for successful intubation. There are three axes that must be aligned in order to have an effective intubation. Looking down into the patient's mouth reveals the oral axis. The pharyngeal and laryngeal axes cannot be seen because the head is in the way, but are nonetheless present because of the neck's natural curves. Successful intubation is dependent on aligning the oral and pharyngeal curve with the laryngeal curve. Axis alignment is done by extending the patient's neck. With the clinician standing at the head of the bed and the patient lying in the supine position, the laryngoscope is inserted into the mouth from the right side, moving and trapping the tongue over to the left, out of the line of sight. This maneuver makes a view of the glottis possible. Realize that the blade of the laryngoscope is within the vallecula. Lifting the laryngoscope upward, one displaces the hyoid bone upward, which in turn pulls on the hypoepiglottic ligament, which consequently moves the epiglottis upward, allowing visualization of the larynx. Here is the hyoid bone and the thyroid cartilage. As you can see, they are in the same plane. In the neutral position, the hyoid bone is dorsal to the thyroid cartilage and glottis. The stylohyoid ligament acts like a cable by which the larynx is suspended and adds tension to keep it back against the pharyngeal wall. The whole point to laryngoscopy is to get the hyoid bone anterior to the thyroid cartilage. This is done by placing the laryngoscope in the valleculi sweet spot, which facilitates rotating the entire larynx forward. Remember, the line of sight must have the hyoid in front of the thyroid cartilage. Lifting the head helps release the tension on the stylohyoid ligament and facilitates laryngoscopy. By aligning the external auditory meatus with the sternal notch, one takes tension off the stylohyoid ligament, allowing the hyoid bone to be anterior to the thyroid cartilage. One way to take tension off the stylohyoid ligament is to place a bunch of pillows underneath the patient's head, lifting up. Here you can see the laryngoscope working its way down the dorsal part of the tongue into the vallecula. Also notice that the hyoid bone is anterior to the thyroid cartilage. Once in the proper position, the epiglottis can be lifted out of the way, revealing the larynx. Lemon is a mnemonic used to predict a difficult airway. Everything we do in healthcare is assessment-based, not just doing it for the heck of it, and the airway is no different. The L stands for look externally. Are they morbidly obese? Do they have any facial hair? Do they have any protruding teeth or protruding tongue? Is there a goiter? Any masses? Have they had a previous tracheostomy? Or do they have any radical neck resections that are preventing mobility? The E stands for evaluate, using the 3-3-2 rule. The first three evaluates how much area you have to work with. The laryngoscope and the ET tube must be able to fit, and you must be able to see 2 to 3 finger breadths. The second three is the thyromental distance. It's the tip of the chin to the hyoid, and it evaluates how anterior or posterior the trachea is, the space the tongue gets pushed into during laryngoscopy. The 2 is the distance from the hyoid to the thyroid cartilage. It evaluates how far away the larynx is. Do I need to use a longer blade? Ideally, the patient will have a 3-finger mouth opening, a 3-finger from tip to chin hyoid, and a 2-finger from hyoid to thyroid cartilage. M stands for the Malampati score, and you can actually do this on each other. If you can see the full view of the uvula, this is a good indication that intubation may not be difficult, compared to class 4, which allows no visualization of the uvula. The O stands for obstruction. It's an evaluation for stridor, foreign bodies, or other forms of sub- or supraglottic obstructions, and it should be performed in every patient prior to laryngoscopy. With stridor, there is oscillations of the airway walls which result from a narrowed airway. Its presence suggests significant obstruction within the large airways and can phonetically sound like the letter E while inhaling. It is a phenomenon that is acoustically explained by Bernoulli's principle, which states that as the speed of a moving fluid increases, the pressure within the fluid decreases. Well, when airflow is forced through a narrow tube, its speed increases, which creates a vacuum distal to the obstruction, causing the airway walls to collapse and vibrate. And last but not least is neck mobility. What are the things that are going to prevent the neck from fully extending and allowing the hyoid bone to be anterior to the thyroid cartilage? So things like arthritis, neck collars, ankylosing spondylitis, and rheumatoid arthritis are among several examples.